The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Thank you so much for joining the Fight Colorectal Cancer webinar. My name is Sharon Worrell. I'm the Senior Manager of Education and Research here at Fight Colorectal Cancer. And today's webinar is Managing Colorectal Cancer Symptoms, How Palliative Care Can Help. So today's webinar, we're excited to introduce Dr. Beth Popp. A couple of technology and background for the folks listening real time. If you guys have a question at any point during the webinar presentation, please feel free to ask a question in the panel on the right side of your screen. There's a section there where you can type in your question and it will pop up on my side of the computer. We will save question and answer for the end of the session, but at any time as questions come up, please type those in to the panel. The webinar is being recorded and will be archived at fightcrc.org/webinar. Following the webinar presentation, you can visit the website to rewatch the webinar session and to access the slide deck. If you do have Twitter, please tweet along with us. Follow the hashtag CRCwebinar. Fight CRC offers a number of free patient resources. We have our Tabooty podcast. We have mini magazines on a variety of topics like skin toxicity, clinical trials, side effect management, and more. And of course, we have our clinical trial finder. Sorry about the formatting issue here, but we do have our clinical trial finder. You can access that at fightcrc.org. The information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. And with that, again, excited to introduce Dr. Popp. She's an associate professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai in New York. Excuse me if I mispronounced. She has dedicated her career to improving cancer and quality of life for cancer patients and is really an incredible, wonderful doctor. We're so thrilled to have you here, Dr. Popp. I will go ahead and hand the controls to you and let you go ahead and begin the presentation.
Thank you so much for the introduction, Sharon, and I'll say hello. I realize folks are listening from different time zones, so I'm not sure whether I should say good morning or good afternoon. So I will just start out by saying hello. It's really been a pleasure to partner with Fight Colorectal Cancer, both in putting some information for the folks who come to the organization to get resources during their cancer journey for themselves personally or for their loved ones, some information about palliative care on the blog, and then this webinar today. So what we'll do today is spend some time clarifying what palliative care is and how it can benefit you. And bear with me for just a moment. I need to do a little technical changes so that I can best see my own slides. Sorry. Where palliative care comes in for those who have colorectal cancer, whether it's an early stage colorectal cancer or it is advanced or metastatic disease. And I will use those terms pretty much interchangeably. So we'll have some time where I will sort of preempt with most of the most frequently asked questions. And then we will have some time for those of you who are listening to ask your own questions. You can submit them at any point through the chat link on the webinar software. And Sharon will look through those and ask them on your behalf towards the end of the webinar. and I will refer you frequently to getpalliativecare.org, which is an initiative of the Center to Advance Palliative Care. As a resource, it has lots of things which I will point out to you as we go on. Some of them are general information and some of them are specific to patients or loved ones of patients with colorectal cancer. So let's start out just talking about what palliative care is. It's a term that some people are not familiar with, and even those who may have heard it before sometimes have misconceptions. So I think it's really always important to start out being clear about what palliative care is so that we're all understanding the same information from that term. Palliative care is specialized medical care for people who are living with a serious illness, and that specialized medical care focuses on relief from the symptoms and the stress of the serious illness. The goal of palliative care is to improve quality of life for both the patient and their family or loved ones. And thinking about the name of the organization, I sort of think of palliative care as a way to help you fight to live your best life while living with colorectal cancer. Palliative care is provided by a specially trained interdisciplinary team, and the team members work together with the patient's other healthcare providers to provide an extra layer of support. It's appropriate at any age and at any stage of a serious illness, and it can be provided along with disease-focused care. Treating the pain and the symptoms and the stress of cancer and what comes after is really as important as treating the tumor itself. And sometimes the oncologist seems most focused on treating the cancer, and people who are living with cancer are not only living with their disease, but with a number of effects of their disease, and those can be things like insomnia and fatigue. Weight loss is probably more common in patients who have colorectal cancer, but sometimes patients have unwanted weight gain. Patients can have nausea, they can have pain, and that can be related directly to the tumor, or it may be related to neuropathy, which I'll talk about a little bit more, which can be a side effect of some of the medications that we use to treat colorectal cancer. People can feel worried and sad, and they can have a host of other impact that their cancer and cancer treatment can have on their lives. And when serious illness strikes, we want to treat the disease. We want to make it go away for as long as we can. Oftentimes we're in a position where making it go away and stay away forever is possible. And sometimes we're in a position where we can make it go away, understanding that it's likely to return, but we would like that time where it's not a significant part of our life to be as long as possible. If we can't make it go away completely, we'd like to slow it down. And we always want to minimize the way it impinges on the ability to do the things that matter most to us as we go through our lives. And what that means is can be very different, because what matters most to each of us is a very personal set of priorities. But for almost everyone, there are elements of trying to maintain good function and maximize quality of life. Again, understanding that how we define a high quality life or our best life is a very personal construct. We want to make sure our care is coordinated and that we feel connected to the people who are taking care of us, and feel like the people taking care of us are connected to one another in their efforts to help us through what we're going through when a cancer illness is part of our lives. And we want to have support that helps us make informed decisions and make the best decisions we can given the information that's available. And that's a tall order, but it's really not that complicated to realize that those are the things that are important to people who are going through cancer. And the healthcare system has really evolved as a sick care system more than a healthcare system. It focuses responding to sickness rather than promoting health. And there's been an enormous focus on technology and not as much value as we've learned that patients and families really care about with regard to how important quality of life is. And until relatively recently, physicians, and I'll add also other healthcare practitioners like nurses or social workers or physical therapists and respiratory therapists, were not trained to assess or address pain and other kinds of symptoms or distress that can occur in serious illness. That's something that we've really seen change. I've been a physician for a little over 30 years, and it's certainly something that I've seen dramatically change from the time that I started my training compared to the training that young physicians and medical students are receiving now. We still have a long way to go, but we have certainly come to realize these priorities and that there were deficits in what we were teaching physicians in order to help them best meet the needs of patients and their families. And we continue to try and do better in recognizing and addressing these important issues that cancer patients and cancer survivors and their loved ones face. And that is exactly where palliative care comes in. ASCO, which is the American Society for Clinical Oncology, that's the professional society for oncologists in the United States, and it encompasses primarily medical oncologists, who many of you know are the physicians who use medications to treat cancer, but also radiation oncologists, physicians who use radiation to treat cancers, and also surgical oncologists, physicians who do operations to treat cancer. We often work in concert with one another, medical oncologists, radiation oncologists, and surgical oncologists, and we work along with nursing colleagues who are specialists as oncology nurses, and many other kinds of specialists. But ASCO 2 years ago updated their clinical practice guideline and recommended that patients with advanced cancer, whether they're in the inpatient or the outpatient setting, should receive dedicated palliative care services early in the disease course, together with active treatment, meaning treatment that's directed at their cancer. And this was really a shift that had been evolving to introduce palliative care earlier. Referring patients to interdisciplinary palliative care teams is the ideal, and services can complement existing programs. Providers may refer caregivers of patients, so the loved ones or family members who have of patients who have early or advanced cancer, to palliative care services. Certainly anyone who's experienced a cancer illness understands that it's not just the patient with a tumor who is affected by cancer, but really their circle of friends and loved ones are all affected by it. As I mentioned before, when we first got started, palliative care is something that is still not very well known among the public. CAPC, the Center to Advance Palliative Care, had commissioned a survey back in 2011 and updated the information surveying the general public just recently, earlier this year. And when we talk to adults throughout the age spectrum of adulthood, starting as young as 25, really a minority, somewhere just over a third, knew what palliative care was. they weren't able to rate whether they what their overall impression was in terms of being favorable or unfavorable, because they simply didn't really know. And that was actually a smaller percentage than we had seen back in 2011 when the first survey was done. Knowledge about palliative care is higher among older adults when the data was analyzed looking just at adults over age 65. About half of them were not able to rate their opinion about palliative care earlier on, and that was down to 42% now. So in both age groups, the ability to rate the impression of palliative care had gone down, but older adults, the numbers were a little bit higher than younger adults. Once people were informed about palliative care, almost everyone thought that they would consider palliative care for themselves or their families. And again, a very high percentage, almost universally, the survey respondents believed that patients should have access to palliative care at any hospital. And a little over 3/4 of the respondents strongly agreed that it was important that patients and their families be educated what palliative care is, and that it's available together with curative or disease-directed therapy. And I think that's really where today's session comes in, and all of you are getting, hopefully, that education by spending this time with us today. So let's talk a little bit more specifically about palliative care and early colorectal cancer. And then we'll shift gears and talk a little bit more about advanced or metastatic colorectal cancer. When we think about early colorectal cancer, patients often don't have any symptoms from the disease itself. Often they are diagnosed because they've undergone a screening colonoscopy. Or they may have very subtle symptoms like having seen some blood in their bowel movements, but not having pain or shortness of breath or other kinds of significant physical symptoms. Some patients may experience symptoms from treatment, and that really is an issue when the illness itself doesn't make someone have symptoms. Sorry about that. But the treatment to make that relatively asymptomatic disease go away, and with early colorectal cancer, we're often trying to make it go away and stay away for the rest of the patient's life. So sometimes those symptoms are not managed by the cancer care team, and if that's the case, then those patients would really benefit from palliative care specialists and a palliative care team to help manage the symptoms that are related to treatment. Most of the time, symptoms that are related to treatment are managed by the cancer care team, whether those are surgical oncologists or radiation oncologists or medical oncologists, working alone or in concert with one another. And so it's less common that the palliative care team is called in for early colorectal cancer patients, but it's neither wrong nor inappropriate to utilize that resource. Treatment for early colorectal cancer can be surgery or chemotherapy, and oftentimes it's a multi-staged treatment plan where patients may get chemotherapy together with radiation, followed by surgery, and then they may get some more chemotherapy afterwards, or they may get chemotherapy first and then surgery and then radiation therapy. And because there are these multiple approaches and multiple specialists who are involved, it can make communication with the care team a little bit more complicated. And because coordination of care is one of the things that the palliative care team can facilitate for patients who have serious illness, that's another way, in addition to managing symptoms, that a palliative care team can be very helpful to someone who has early colorectal cancer. So there are a couple sort of domains or buckets that I think about when I think about how the various ways a palliative care team can contribute to the care of a patient who has early colorectal cancer. The first bucket, which is in some ways the biggest bucket, is pain and symptom management. Pain is one of those things that when people think about cancer, they worry about whether it will be, there will be pain associated with the illness, and palliative care specialists are often the local experts at pain management for pains that are related to a serious illness, as opposed to pains that can be related to an accident or injury. Some of the medications can affect the nerves that transmit pain sensations, particularly in the fingertips and the feet, and that effect on the nerves is called neuropathy. It's something that can be experienced during treatment and is really variable in terms of how significant of effect it has. It's related to some specific medications, and some of the medications that have a propensity to cause neuropathy are medicines that are commonly used to treat colorectal cancer, and managing that symptom so that patients can get the best treatments to manage their disease is something that can really be a helpful addition by involving the palliative care team. I think the second most common question that medical oncologists get about cancer treatments is whether or not it will make them nauseated. That's really an association that many people have with the medicines that we use, chemotherapy medicines in particular, that treat a lot of cancers. And palliative care specialists usually have expertise in managing nausea, whether it's related to chemotherapy treatment or related to the tumors itself. Patients with colorectal cancer, because the colon and rectum are the involved parts of the body, often have changes in their bowel habits, and those can be further impacted not just by the tumor itself, but by the surgery or radiation treatments or the medicines that are used to treat the tumor. Some of the medicines that we use affect the way taste for food and drink is. We mentioned weight loss or weight gain that's undesired. And many of the treatments can also impact the patient's energy level in a way that can limit their ability to participate in activities that are important to them, and trying to mitigate that fatigue is another way the palliative care team can be of benefit. The next bucket or group of ways that the palliative care team can really be of benefit to the patient and family are psychological support. And that sometimes falls to the physician member of the team, but it also falls to the social work member and oftentimes nursing members of the interdisciplinary palliative care team. And those can be issues about body image. Patients who have surgical treatment for colorectal cancer often have scars. Sometimes either temporarily or permanently, they need to have a change in how their bowels empty with a colostomy or an ileostomy. And that can be a very big adjustment for some people. Some people take it in stride relatively easily, and other people really benefit from some assistance in adjusting to the way their body looks and feels differently. Worry or anxiety is also something that is not uncommon. I would actually say it's quite common for patients who have any serious illness, and I think there's so much psychological and societal valence that comes from a cancer diagnosis rather than other serious illnesses that can create a lot of worry or depression or sadness. And for many people, those things are transient. Sometimes worry or sadness is about a specific aspect of care, which is unknown. I don't know what radiation will be like. And once it starts, it's less worrisome because it's less unknown. Or I don't know what chemotherapy will be like. And once it starts, it's less unknown. So it can minimize the worry that's present. Sexuality can be affected, and part of that can relate to body image. Part of that can relate to aspects of treatment in terms of energy level, in terms of pain, and there are important ways where our sexuality is a part of who we are and how we maintain our relationships, and how we express our love and affection for people who are close to us, and understanding how that may change during a period of cancer treatment is another way, and learning, helping people adapt to those changes is another way that the interdisciplinary palliative care team can be of help. The third bucket is decision-making support, and that is an area that we talk about, and the term that you may hear used if you work with a palliative care team or read some of the information that's available on the getpalliativecare.org website or other resources, is understanding the goals of care for the patient. What is the patient hoping for in terms of how treatment will help them? Sometimes there are multiple different kinds of treatment that can be offered, and varying degrees of certainty or uncertainty about what that will bring in terms of both benefit and results, and in terms of possible side effects, and how that may impact someone's life or important activities. One example would be for someone who is a professional musician who plays the violin or the cello, may opt for a treatment that is less likely to cause neuropathy, the issues with the fingertips having less sensitivity because it impacts their ability to be a musician. And so understanding whether there might be an alternative treatment that would have less impact on their ability to apply their craft would be an important aspect of decision-making support. And then we talked a little bit before about care coordination. Increasingly, cancer care is a complex endeavor that involves clinicians from a variety of different specialties, and helping to make sure that care is coordinated among them, and that some of these important, very personal, value-laden aspects of decision-making are clear to all the members of the team, and that decisions are made in a coordinated fashion that incorporates who the patient is and what their values are, is something that the palliative care team can really add. So let's shift gears for a second and talk about palliative care and metastatic or advanced colorectal cancer. In metastatic disease, and just again to be clear and make sure everyone understands the term, metastatic disease means that the tumor has spread to an additional location that's not directly It's not from expansion of the original tumor getting bigger, but it's spread to a different location. And because when a cancer or a tumor spreads to a different location, we often find out about that through symptoms that patients experience. And so oftentimes in patients who have advanced or metastatic disease, they know something is going on. Those are patients who are more likely to recognize that there's a problem because of pain or shortness of breath or weight gain or other kinds of changes in how they feel physically. And those symptoms are really balanced against the symptoms that may come from treatments to decrease the tumor or get rid of the tumor. And there are many new therapies that really have changed how that balance is struck between symptoms that are caused by the disease itself and symptoms that are caused by treatment for the disease. And the early inclusion of palliative care has also made a big change and has been a way that we can shift that balance in a very active way, in a favorable way, so that people have improved outcomes and have a better quality of life throughout the course of their disease. When we think about the ways that palliative care can help patients and their families when metastatic colorectal cancer is what we're dealing with rather than early colorectal cancer, we have some similar buckets. Pain and symptom management, for all the reasons that I described previously, are significant issues, again, either because of treatment or because of the location or size of the metastatic lesions themselves. Psychological support, it can be very important, and a further expansion of that psychological support can often be spiritual support. The nature of metastatic colorectal cancer is such that people can have concerns that are more existential or spiritual, and while they could happen, and patients with early stage disease can have those concerns as well. My experience, and certainly the experience of my colleagues through the field, is that spiritual support becomes a more common and more prominent issue for patients who have metastatic or advanced disease. Again, like patients with early stage disease, there are important contributions that the palliative care team can make to facilitate clarification of goals of care, to help patients with treatment decisions, care coordination, and decision making. And because metastatic colorectal cancer can often have a longer course of treatment with many different kinds of treatment being utilized in sequence, those decision-making and care coordination issues, as well as making sure that the patient's goals for their care are always carefully considered and incorporated into decisions, can become a bigger and more important aspect than they may be for patients with early stage disease, who may have a more finite and clearly defined length of treatment. So I'll share with you two anecdotes about patients who I've cared for as a palliative care clinician. As you heard in the introduction, I actually trained as a medical oncologist in addition to training in palliative care, and much of my work, and currently all of my work clinically, is taking care of patients who have cancer and working with my oncology colleagues to provide palliative care as a component of the cancer care that our patients receive. So one patient who comes to mind is a patient who had a rectal cancer that was treated with chemotherapy and radiation, followed by surgery, and she had very successful treatment, but became profoundly depressed, and it was really quite difficult for everyone around her to understand her depression and to help her get to try and accept treatment for her depression. She was somebody who had been born outside the United States and whose first language was not English. And even though many of the caregivers, physicians, nurses, and therapists who were taking care of her were able to speak to her in her primary language, and those who couldn't spoke to her using skilled translators, it was very difficult to get through some of the barriers to understand her depression and to try and help her manage it and improve it. And in that setting, she was referred for palliative care. One might have thought that she would be referred to a psychiatrist for depression, but for a variety of reasons, she was referred to palliative care. And in talking to her and having the interdisciplinary team do a full assessment, what came out was that even though she had done very well in terms of her cancer treatment being quite successful, this woman had a daughter, an adult daughter, who lived with her, who was significantly disabled with both physical and intellectual disabilities. And the experience of this serious illness, even treated successfully, really had created a crisis for this patient in having to think about the fact that even though this treatment had been successful, she needed to have a plan, and that another crisis and another kind of illness could strike, or she recognized there was a possibility that even though her cancer treatment had been successful, it could come back. And she didn't have a plan that she was comfortable with for how her daughter's needs would be met if she wasn't able to meet them, either because she became too sick or eventually if she died before her daughter did. And she tried to bring this up a number of times with her other children, and none of them would talk to her about it. They said, "Mom, you're fine. Everything was good. The doctor said your treatment was successful. We shouldn't be talking about this." And the more her family was unwilling to talk about it, the more worried she became about it. It seemed sort of paradoxical. And what we were able to do was to facilitate a discussion about what the patient's concerns were as a separate issue apart from her cancer, because her cancer treatment had been successful, and getting her family to acknowledge that her concerns were important to her, even if they seemed unrealistic to the other children in the family, allowed the patient to address those concerns and accept treatment for her depression, which was much easier to treat and much less serious when what were the underlying concerns were able to be addressed. A second patient who comes to mind is a patient who had, again, complicated early stage cancer and then developed very severe pain that really seemed unexpected in the course of her treatment, and for that reason she was referred to our palliative care team. It wasn't clear initially why she was having pain, and we were quite worried that it might mean that her cancer had recurred. She was quite worried about that as well, and she started to take her pain medicines in a way that was concerning to some of the doctors who were involved, that it might be because she was trying to manage her worry inappropriately with pain medicines and not recognizing how severe her pain was. It was through the careful evaluation and everyone talking together, the surgical oncologist, the radiation oncologist, and the palliative care specialist, were able to find out that because this patient had some other health problems, which included diabetes, she had developed some issues with internal wound healing long after her treatment had finished. And that was the cause of her pain. She wasn't taking her pain medicine inappropriately, but rather she was taking her pain medicine very appropriately for pain that was very rapidly getting worse as this problem developed. And when the issues with wound healing were recognized and able to be addressed, her pain required a second surgery, and her pain went away really remarkably fast, and we were able to work with her to successfully decrease the pain medicine. She was very worried by that point that she was going to have difficulty stopping to take opioids. They're the strong pain medicines that we have to use for some strong pains. There's a lot of information in the lay press about people who misuse medicines not under medical treatment, and that had caused her a great deal of worry, but we were able to decrease her medicines in a systematic way so that she had no pain, no side effects from decreasing the medicine, and when she no longer, because her pain had been addressed in terms of the underlying root cause, she no longer had any need for those medicines and was able to stop taking them. So those are two examples of ways that patients, both for psychosocial support and for physical symptom management, can benefit from the involvement of the palliative care team working in concert with their primary cancer care team. With the information that I provided, as well as thoughts about those two anecdotes, I will share with you now what some of the most common questions we get asked about palliative care are, and then we'll have a few minutes for questions that those of you who are listening may have. So when should someone get palliative care? Palliative care is the right time for it is really when you need it. And I don't mean for that to be circular or flip in my response, but it's really based on having uncontrolled symptoms or difficult to manage psychosocial issues related to treatment. It really doesn't have anything to do with how well someone is expected to do in terms of making their cancer go away or how long we think we can make it stay away. Palliative care is appropriate for anyone at any age or at any stage of their disease, and they can have it at the same time that they are receiving care that is focused on treating their disease, trying to make it go away, or trying to slow it down. And who are the patients who should get palliative care? It's anyone who's in need of relief from pain or other symptoms and stresses that come from having a serious illness. We're really engaged with the patient and the other clinicians who are caring for the patient with a goal of improving quality of life for the patient and their family. And again, any age, any stage, and together with disease-focused or curative treatment. The ultimate goal of palliative care is to help people have the best quality of life that they can while they are living with a serious illness. And what happens? What's the impact of palliative care being a component of someone's cancer care when they have colorectal cancer? Well, palliative care specialists working together with other cancer specialists are more effective in relieving pain and symptoms. Patients may live longer, and I'll come back to that one in a second. Patients, families feel more supported. Patients spend less time in the hospital and less time going to the emergency room. And almost everyone I have ever met wants to spend the least amount of time possible in the hospital or in the emergency room when they're sick. And tests that may be unnecessary and unpleasant, and procedures that may be unnecessary, unpleasant, happen less when the palliative care team is involved, because the palliative care team can often help focus the care more precisely on the patient's goals. I'll come back for a moment to the notion of patients may live longer. One of the most important palliative care studies that was done in the brief time that palliative care has been recognized as a specialty within medicine, and that's really probably less than 20 years, is that was done, the lead author was Dr. Jennifer Temmel, who is in Boston, at part of the Harvard hospitals. And they looked at patients who had advanced lung cancer, who got referred to palliative care specialists soon after they were diagnosed, rather than waiting until their cancer care team thought that they had difficult to manage symptoms or a need for additional support. Just simply because of their diagnosis, they were referred. And when we looked at, not only did those patients feel better, but somewhat unexpectedly, they saw that the patients who were referred early to palliative care, not based on their symptoms, but simply based on having a high-risk lung cancer diagnosis, actually lived longer, about 3 months longer, than patients who were referred when they had symptoms that were recognized by their cancer care team. So we know that some cancer patients who receive palliative care early do live longer. That study has not been replicated in patients who have colorectal cancer, but certainly a huge amount of research which has gone on in the last few decades has shown us that palliative care patients live better because of control of their symptoms. And while we're always happy when we're living better to also live longer, we may actually, by helping people live better, be able to help them live longer. Oftentimes there's a perception that people have to make a choice between feeling better or living longer. And one of the things that the Temmel study showed us is that that may not necessarily be a trade-off, but may actually be something that those two goals facilitate one another. One of the questions that comes up extremely frequently is whether or not people can have what you've heard me refer to as disease-directed therapy, so chemotherapy, radiation, or cancer surgery, and receive palliative care. And the answer to that question is absolutely they can. There is no dichotomous choice between having palliative care and having cancer treatment. Palliative care can be given alone if that is a choice that a patient makes, that perhaps because of other health problems they have, or other beliefs that they have, or what their goals are, they don't want treatment for their cancer at a point in time, then they can get palliative care exclusively by itself. But if they make a choice to have cancer treatment, whether it's surgery or radiation or chemotherapy or immunotherapy, any kind of medications to manage their cancer, they absolutely can get palliative care together with that. So should the patient bring it up, or should they wait till the doctor suggests it? That's another really common question. And it really can go either way, but if you or someone who you care about, you think would benefit from palliative care, don't wait for the doctor to bring it up. There's no reason not to bring it up and ask the question themselves. It's more common that people will ask their doctor for the referral to palliative care. And keep in mind, we have a complicated healthcare system. There are issues about access. So palliative care teams are considered specialists, and depending on what healthcare system you're a part of and how you access your healthcare, you may have to have the primary doctor make a referral or request to bring in the palliative care team. So that's certainly something that each person, by the time they've gotten to a cancer care specialist, usually knows how their healthcare access issues are through their health insurer, but that's something to keep in mind. Who are the people who provide palliative care? That's another common question. And the palliative care team is a group of palliative care specialists, and those include physicians, nurses, and a variety of other people. They can be social workers and chaplains. For colorectal cancer patients, an enterostomal therapist is often a really important member of the palliative care team. And they can also be music therapists, can be extremely helpful in enhancing patients' ability to manage some of the side effects and stresses that come from their disease or its treatment. Palliative care can be provided in a variety of settings. Hospital-based palliative care has been a place where palliative care really grew and developed during recent times, but outpatient palliative care is becoming increasingly common. I work exclusively in the outpatient setting at this point in my career. Patients can get palliative care in their homes through home visiting palliative care teams, and there are often palliative care teams in rehabilitation facilities, whether those are acute rehab centers or long-term or subacute rehab centers. So if you're struggling with pain or other symptoms or stress due to cancer or its treatment, you should ask your doctor for a palliative care referral. Let them know that you think you could benefit from an extra layer of support. GetPalliativeCare.org, which is an initiative of the Center to Advance Palliative Care that is focused on patient and caregiver and family members' education and information, includes a very robust provider directory. So you can see where there are palliative care specialists and palliative care teams located in your geographical area or within your healthcare system. And on that website as well, there is a great 5-question self-assessment so that you can understand whether palliative care would be right for you or your loved one, and information on how to get it, including ways to coach you on how to talk about it with your doctor if you feel like you need some help understanding how to bring it up. There are real stories and free podcasts that include a number of patients living with colorectal cancer who have benefited from palliative care. And just like Fight Colorectal Cancer provides educational webinars like today's, GetPalliativeCare.org provides webinars on managing specific symptoms and living with different serious illnesses. And again, I really want to thank Fight Colorectal Cancer for partnering with the Center to Advance Palliative Care in providing today's webinar. There's a provider directory that's searchable by location, by state, and has community-based listings as well as hospital-based listings, and a downloadable handout that's entitled What You Should Know that provides some clear and brief information about palliative care. So we're getting close to the end of our time, and I will just say that colorectal cancer patients are living longer than ever before. Patients often have symptoms that need to be addressed by specialists, and they can be addressed by their oncologist or their primary doctor, but if they're not able to for whatever reason, then palliative care specialists are there and can help address them. And sometimes those symptoms occur during treatment, and sometimes those symptoms are related to prior treatment and can occur in cancer survivors who may have some longer term effects related to their previous treatment that was successful. Cancer and the symptoms of cancer can and should be treated. Palliative care improves the outcome for patients, and patients and family members can ask for palliative care when they think it will be helpful to them. So let's take a minute now, and Sharon, I think we have a couple minutes for questions.
Yeah, thank you so much, Dr. Popp. We do have a couple questions coming in. If we don't have time to get to all of your questions, we can follow up definitely via email. Feel free to email me at sharon@fightcrc.org, or we can do a follow-up blog as well. So let's see. Okay, so we have a question here that came in. What can a patient do if palliative care is not available in their area or within their healthcare system? Specifically thinking of rural areas, is telemedicine an option for palliative care?
That is a great question, and that is exactly how many rural areas and other areas where there are limited access to palliative care are trying to address that problem. We're also using technology to try and improve what's called primary palliative care, which is improving the knowledge and skill set for people who are not palliative care specialists, to be able to provide some basic palliative care symptom management to their patients, especially in areas where specialists may not be available. And that's in those areas you can probably be familiar with a similar kind of arrangement. Many of those rural areas may have a specialist in other areas like a cardiologist or a gastroenterologist who is available once a month, and management of problems in between time is done by a family physician or a primary care internal medicine specialist. So we're developing those kinds of partnerships with our colleagues in areas where patients are underserved by palliative care specialists. Great question.
Dr. Popp, how can palliative care help my family? Is this a type of medicine that extends beyond just the patient?
So that's also a great question. And we talk in palliative care about how the patient and the family are the unit of care, that we are not just there for the patient. Yes, the patient is the one who has the diagnosis and the tumor, and maybe the person who has the surgery or the radiation, but everybody is affected by it. And we recognize that and will work with the family members. Obviously, we can't, from the physician end, we can't prescribe medicines for people who are not our patients, but we certainly can work with the other members of our team in terms of education and in terms of psychosocial support and spiritual support in getting their input into decision making and understanding how different decisions that might be made about treatment can impact the whole family. And other contingencies that might bring to bear. And that's a really important way that family members benefit from the involvement of the palliative care team.
Thank you, Dr. Popp. So we are at the end of the hour. I do see your questions coming in, and I will forward those along to Dr. Popp and be able to respond to these questions after the webinar via email. But Dr. Popp, I do want to thank you so much for your time to taking your time out of your day to present to the Fight Colorectal Cancer community about the importance of palliative care and how it can help them. And thank you so much to all the listeners who joined in live. Again, the webinar recording can be found in the webinar archives at fightcrc.org. Thank you again so much, Dr. Popp, for everything.
It was really my pleasure. Thanks so much for having me.
Thank you. Have a great day, everyone.
Bye-bye.
Bye.